Lori, you're muted.
Are you able to see that now?
Yes.
I think when the webinar started, it took down the share screen that I had going on before.
All right. Hello, everyone. Welcome to our Inception Lunch and Learn session. Today, we will have Lori Black and Amy Duckett walking us through their topic today about medical updates and adverse outcomes and how to manage those in fertility care. A quick overview of our Zoom platform today. If you have any questions, feel free to put them in the Q&A box, and Lori and Amy will answer them either through the session or at the very end. You can also utilize the chat feature to say hello to everyone else that's on the session here, or to put in any technical questions that you may have. If for whatever reason you need to drop off early or would like to share this session with other team members, don't worry, you will receive a recording of the session tomorrow morning, along with an email that has all of our other sessions as well. So if you are here a manager or someone that works with a lot of clinical team members, please feel free to share this as a reference so they can all get this great information that we have here. And without much further ado, I will hand it over to Lori and Amy.
Thank you so much, Rachel. And thank you all of the attendees for taking time out of your, I'm sure, very busy clinical schedules to learn a little bit more about how to manage medical updates from patients and donors and things that we might consider some adverse outcomes. So just by way of introduction, I'm Laurie. I'm the Inception Director of Genetic Services. I'm a genetic counselor by training, been in the field for 25 years as a genetic counselor in reproductive medicine, and have been with Inception in this role for the past year and a half. And you may have seen me in other lunch and learns. And I am very grateful to be presenting today with my colleague and friend, respected Amy Duckett. I'll let Amy introduce herself.
Hi, everyone. I am Amy Duckett. I currently work with My Egg Bank, and I have been in the third-party world for the last 10 years, starting off at RBA's Egg Donor Program. I am an attended parent coordinator, as well as the genetic counseling liaison for My Egg Bank, and I have learned a wealth of knowledge from Ms. Black, and I am very happy to be here with you guys.
All right, thanks, Amy. So just getting us started, during this lunch and learn, we've got a few learning objectives. We're hoping that at the end of this, you're going to be able to identify some new medical information and when that new medical information that's been given to you warrants some follow-up, whether that's received from a gamete donor or a patient recipient, or it's information about a pregnancy or a child conceived either from autologous gametes or donor gametes. And then we've got some recommendations for the clinic and donor programs about what information is really essential for accurate risk assessment. And we're going to illustrate the importance of medical records and how communication with patients and donors can go and some of the challenges. And then we want to talk about consideration of follow-up genetic testing when that's indicated. So, sometimes there's going to be genetic testing that would be warranted on the gamete providers or a child or donor conceived person. And then there also may be consideration of testing embryos based on an outcome with PGT or prenatal testing. So I'm going to begin, like I do many of my lunch and learns, with a little genetics review. I don't expect you guys to be as giddy as the people in this picture, but hang tight with me. I just want to make sure that we're all on the same page with our foundational genetics knowledge. So just a key point before we delve in, I want you to recall that the objective of a genetic risk assessment is to identify a possible genetic cause for a condition or a pregnancy outcome so that we have the ability to offer some risk reducing options if they're available. And also that genetic risk assessment is a dynamic process. This information can change as new medical information arises during the course of treatment. So it's not something that is static just at the time that you're doing your initial evaluation of a donor or a patient. So quick refresher, remembering that we have in all of our cells, I should not say all of our cells, most of our cells, red blood cells, don't have this. Most of our cells have a nucleus. That's the middle part of the cell that has all the genetic material in it. And the genetic material is arranged into chromosomes. So think of a chromosome as it's just a package of DNA. That strand of DNA is coiled up and tightly compacted into that chromosome form. If you were to stretch out that strand of DNA, you would see that it is made up of building blocks, the A's, T's, C's, and G's, the letter code of the DNA, that form into individual genes. And the genes are it's information to be able to make proteins and enzymes and all the things that our cells need to do to function as cells and keep us healthy. So here are pictures of human chromosomes. And when we talk about a picture of a chromosome, a set of chromosomes, it's called a karyotype. So I'm sure you guys have ordered these on donors, on patients, you're quite familiar. And you'll remember that for humans, we should have a total of 46 chromosomes. They're arranged in pairs because half of our set of chromosomes comes from the egg. The other half of the set comes from the sperm that creates us. And the first 1 through 22 chromosomes are numbered, you see, and they're arranged from the largest to smallest. And then the 23rd pair of chromosomes is the sex chromosome pair. So this is where we differ in our biologic sex. So females have 2 X chromosomes, whereas males have 1 X and 1 Y chromosome. So when we're talking about sex-linked genes, those are on the sex chromosomes. When we're talking about autosomal genes, those are located on the numbered chromosomes. And here is an example, a couple of examples of differences in karyotypes. So you can see here that there is an extra copy of chromosome 21, and so that is also called trisomy 21 or Down syndrome. This tends to be just a completely sporadic and random, not inherited chromosome abnormality or aneuploidy. Over to the right side of the screen, we have an example of a reciprocal translocation. This is a chromosome rearrangement. So for this person, they have the correct amount of chromosome material. It's just in a rearranged format. Part of chromosome number 4 has broken off and switched places with a broken part of chromosome number 12 in this example. Chromosome rearrangements can affect any chromosome, and males and females are equally likely to carry chromosome rearrangements. Oftentimes people that carry these are totally healthy and don't realize it until they start to have reproductive issues, because people that carry chromosome rearrangements are more likely to make eggs or sperm that have extra missing chromosome pieces and can then lead to miscarriage or babies born with problems. Can also cause infertility. Now, when we drill back down to the DNA and the letter code of the DNA, there can be differences there as well. So changes in the letter code of DNA of a specific gene, it's called a variant. And kind of older, maybe more familiar nomenclature is a mutation. A mutation is a specific kind of variant. It's a variant that is known to be pathogenic or likely pathogenic, meaning it's known to cause disease. There are other kinds of variants that we can see that are benign, or maybe we have never seen them before and we're not really sure how to interpret them, and they're called variants of uncertain significance. But what we used to call mutations that we now call either pathogenic or likely pathogenic variants are what we're looking for when we're doing carrier testing. So when we're thinking of individual genes, there can be different modes of inheritance for the conditions associated with those genes. And this is a simplified explanation of single gene inheritance, but it may sound somewhat familiar for you. Over to the far left, we have dominant inheritance. So that's a situation where a parent is affected with that single gene condition, for example, Huntington's disease, and they have a 50-50 chance of passing that on to a child. And it doesn't matter whether that child is male or female, it's a 50-50 chance that they would inherit from either a male parent or a female parent, that pathogenic variant, and be affected with that dominant condition. In the middle, we have autosomal recessive inheritance. So again, remember I was saying autosomal means it's on one of the, the gene is on one of the numbered chromosomes. So it equally affects males and females. So autosomal dominant, autosomal recessive, equally affecting males and females. But with recessive inheritance, we think of the parents as having one working copy of the gene and one gene with a variant. And so oftentimes they don't know that they're carriers because they don't have any health issues related to that. Starting to learn that that can sometimes not be true. Sometimes carriers can have some impact on their health. But if two people are carriers for the same gene, it doesn't have to be the exact same change or variant in the DNA of that gene. It's just if they have a pathogenic or likely pathogenic in that gene, and it's the same gene, then they're at risk to have a child that's affected. It's a 25% risk. And then over towards the right of the screen, we're talking about X-linked inheritance. So these are genes that are located on the X chromosomes, as the name implies. So females can be carriers, and a woman who's a carrier has a 50-50 chance of passing on the X chromosome that has the gene variant. If a male, a son, inherits that, then they're going to have the condition. Also, sometimes if a daughter inherits that, they may also have that X-linked condition, but it may be milder than what we would see for sons. Okay, so that was just a quick overview. And I'll point out the reason I have a gold block around recessive and X-linked inheritance is because those are the ones that we tend to focus on with carrier screening. With dominant conditions, we don't include those in carrier screening. We would rely a bit more on a family history to identify that risk. And then in addition to chromosomal issues and single gene issues, we have something that's more complex, but far more common, and that is things that are multifactorial. So multifactorial conditions are really a combination, as the name implies, multifactorial, multiple factors of genetic, biologic, and environmental factors. And oftentimes we don't know exactly what those factors are. And some examples of some multifactorial conditions, certain birth defects like a heart defect or club foot, spina bifida, cleft lip, most autism, most cancer, most learning issues, most psychiatric issues, autoimmune issues, diabetes, like there are a lot of things that fall into this multifactorial category. And even though we recognize that there are some genetic factors at play with these conditions, there isn't a definitive predictive genetic test for these types of conditions because it's not just one thing. But because of these genetic factors at play, close relatives like first or second degree relatives, siblings of an affected person, children of an affected person would be at increased risk compared to just the general population frequency of that condition. So we're going to switch gears now and talk about how do we do genetic risk assessment? How do we assess the risk for these types of genetic conditions for our patients and donors? So our first tool is a personal and family medical history. For our patients, we tend to obtain these by a questionnaire. It's very common that they're filling out a questionnaire when they enter care in our clinic. There may be discussions with providers where perhaps the patient says, hey, my cousin has such and such condition. Is it possible to test for that? Or discussion with a genetic counselor. A certified genetic counselor is specifically trained to be able to take a personal and family medical history and try to cull out what may be genetic risk. And then for our egg donors, the donors that we're screening through Inception's central donor recruitment, we have the donor application, which is quite lengthy. And includes lots of personal health and family health questions. And then as a matter of standard, all donors being screened through our central donor recruitment process will have a consultation with a certified genetic counselor, with a GeneScreen genetic counselor. And if you're not already familiar, GeneScreen is our partner third-party genetic counseling service. Not only do they offer screening for our donors through central donor recruitment process, but pertinent to this discussion, they're also able to have consultations discussing adverse outcomes for patients using their own gametes, or if one of our patients has used a gamete donor, to talk about what that condition is, what's the chance it might happen again, is there any testing that could help reduce that risk. So some of our additional tools for assessing reproductive risk, the top two we deal with on a regular basis. So I've mentioned already genetic carrier screening. Right now, Invitae's 556 gene panel for females and 513 gene panel for males is the standard in the network, and that's also what we use for our egg donors. And then also, if we're looking to do testing of embryos, you guys are all well aware, we have PGT options, aneuploidy screening with PGTA for those sporadic and random chromosome abnormalities that can happen in anybody's embryos, but happen more frequently with increasing egg age. If there's a known structural rearrangement in the chromosomes for either gamete provider, PGTSR is an option. And then when there is an identified single gene risk, monogenic or single gene conditions can be addressed with PGTM. And then outside of our purview, but you certainly may hear about it, especially if you're investigating an adverse outcome, there are prenatal testing options. So there are screening, non-invasive options like ultrasound, blood tests for mom, whether that be looking at serum analytes or cell-free DNA that's fetal DNA that's crossed the placenta and is circulating in maternal serum. These are really common to offer. There are also invasive diagnostic options that take a sample from the pregnant CSL sample. So chorionic villus sampling, or CVS for short, is a placental biopsy, whereas amniocentesis is sampling of the fluid from around the baby, and sloughed off fetal skin cells are then isolated and used for analysis. CVS is a first trimester, tail end of first trimester test. Amniocentesis is typically a second trimester test. But those are all available to help our patients address reproductive risk. The one really important take-home message, and sometimes patients with all the genetic testing that we're offering them miss this important point, but with all the tools we have available to us, the family history review, the carrier screening, PGT, prenatal testing, there is no way we can identify all causes of developmental delays, learning problems, autism, various health issues, birth defects. We can't even identify all causes of genetic disease because we don't know the cause of all genetic conditions or all of these conditions. Many of these are multifactorial. And like I said, there's not one single easy predictive test for many of these. So with that setup, and now that you're refreshed on genetics and testing options, let's delve into medical updates and adverse outcomes. And you're going to hear us use those terms somewhat interchangeably, but really a medical update is more of a broad umbrella term. It's basically any new information received after initial screening is complete and the treatment has begun. And it may include maybe a new genetic test result, whether that be an updated carrier screen or maybe some diagnostic genetic testing was done. It could be an update to the personal or family history from a patient, from a donor, or from a child. It also could be pregnancy outcomes for a patient or a donor, whether it's the donor conceived pregnancy for a recipient, or even donor is reporting on her own pregnancy. And internally, we tend to use the term adverse outcome, or sometimes people say adverse event, when the new information is perceived to have a negative impact. It can, and also maybe a strong emotional impact, and potentially can affect their future reproductive decision-making, a current pregnancy, or a child. There is, however, a bit of a movement towards not saying adverse outcome because of the stigma that's associated with it. So just be mindful of that. Maybe while we're referring to adverse outcomes internally, and that's the way we speak to each other, that may be hard for a patient or a donor to hear. So maybe using the more neutral term medical update is more sensitive and appropriate. So just leading us into some examples. So what do we do when a patient who conceived by IUI says that her baby had a positive newborn screen for a genetic disorder? What do we do when a gamete donor recipient says that her pregnancy was affected with a severe birth defect, like a congenital heart defect? How about a patient who conceived by IVF using her own eggs and partner sperm, says that she just ended a pregnancy because that pregnancy was affected with a lethal neural tube defect, anencephaly? Or what about a previous egg donor who contacts the clinic donor program to share some new personal medical information? So any of this could be something that leads us to reconsider what genetic tests might be available, or how we might recommend medical management of a subsequent cycle or pregnancy. So it's all potentially relevant information. And so now I'm going to stop talking and I'm going to turn it over to the lovely Miss Duckett to be able to pick up here and talk about some SOPs, or standard operating procedures.
All right. So when you have an adverse outcome or a medical update with a patient or a donor, there are a lot of moving pieces associated with that outcome. You've got medical records you have to speak to patients, clinicians, doctors, who needs to be notified, what information do they need to receive. It's very fluid, and some of these cases can take months to actually complete. So if you do not have an SOP for your internal team, I would highly recommend having one to keep basically as a timeline. Like, what do I do here? Okay, I got this information 6 weeks later. What do I need to do now? It will kind of keep you flowing better, and we'll know who needs to be updated. And when the case is closed, what do you do at that point? So adverse pregnancy outcomes are pregnancies or children who have been diagnosed with any major malformations, have a genetic condition, or have any kind of significant medical or developmental issue. These are the types of things that you will be notified of via donor, recipient, gestational carrier. And there are so many different outcomes that you could have been notified on. This is just a very small list of the things that Lori and I have worked on together. We've had cleft lips, spinal bifida, heart defects, deletions in chromosomes, hygromas. They're a rainbow, a huge window of things that you may be notified of that need some sort of investigation.
And I'll just add before we go to the next slide that oftentimes people are a little bit at a loss for trying to determine what constitutes a major malformation versus a minor malformation. And at the bottom of the slide here, we've got, and you'll see it again on a subsequent slide, but we've got a link to the Centers for Disease Control and Prevention website for defining birth defects and what constitutes major versus minor.
Mm-hmm. So what can you be challenged with when you're dealing with an adverse outcome? My biggest challenge is communication, keeping the lines of communication open with patients, with clinicians, with coordinators. There may be long periods of time between getting, test A, between test B. I got a report today, actually, for a case that's been open for 6 weeks that we've been waiting on a microarray on. So we have to keep that line of communication open, follow up with your patients, follow up with each other, follow up with us if we're involved. That way we have a running, I have spreadsheets, I have lots of spreadsheets. So I can dictate where things are, where we are in the process, what information I need, who needs to be followed up. So that is my biggest piece of advice. And when you are speaking to recipients, just take into account what they may be feeling. They have gone to the ends of the earth to try to have a child. They receive this information. It could be extremely heartbreaking for them. They may be completely overwhelmed, not knowing where to start. They may cry with you on the phone. They may be a little shameful. They may be very angry and they may direct their anger towards you. But what you have to remember is they have every right to feel these emotions because, again, they have done everything that they could possibly do to have a child. And now there is something that is not going the way it should. And we have to be sympathetic to them, and we have to be, we have to respect their feelings and offer support where we can, keep in touch with what we're doing so they don't feel like that we're just taking this information and saying, okay, cool, thanks for letting us know. So just keep, patients, their well-being basically in mind when you're talking to them. So they feel like that you're on their side and working with them to come up with some sort of resolution, if possible. There are several different components that you guys will be involved in if you're working on an adverse investigation, like what we talked about earlier is consistent communication with both the patient and clinicians. You'll also have to be requesting medical records to be reviewed. If it's possible for your clinic to obtain a medical release for both the patient and the child, it may take some extra stress off the patient on what information they need to receive. Because if we tell them, we need your records, well, what records? What information are you looking for? So if you're able to take that stress off the patient, they might be very appreciative of that. But if not, we're looking to get information on maternal fetal medicine, periodontologists, obstetrician reports, genetic counseling reports, pediatrician, and any other pediatric specialist reports that you could possibly get, or testing to help determine what we're looking at and what we're working with. Based on this information, we may have additional testing that may be ordered. We may suggest different evaluations. There's a whole, again, there's a lot of different things that could be recommended based on the information that is received. All right, so medical records. Medical records. They are essential for review. You may get a verbal report from a patient stating, oh, my child was diagnosed with an extra finger. And you're like, okay, that's fine. That's not a huge deal. But then you request the medical records and you're reading them, and there are 6 other things listed that may be indicating a syndromic type condition. It may have some minute detail in there that is very important for Lori or the genetic counselor working on this. So it is very important to always request medical records so we can confirm the accuracy of the initial report. Again, see if there's any other additional information that wasn't relayed to us, and get a full picture of everything that is going on. Again, some additional examples of medical reports would be the ultrasound reports, any diagnosis testing, clinical notes, and any other testing completed by the patients, including microarrays, whole genome or whole exome testing, or single gene testing as well. Who does the investigation? We all do the investigation. We are all involved at one point or another. The dream would be for each clinic to have a team that works on these events, including doctors, the clinical staff, genetic counselors, GCA if you have one on staff, and any third-party team. And you guys have to work together to, have a file, if you will, of information that you've all poured in together to get everything that is needed to report out the adverse event. Of course, not everyone is blessed enough to have a genetic counselor. So if you do have any questions, Lori is a wonderful resource. She will be happy to help you. And I work a lot with GeneScreen, as a lot of you do, and they have been amazing too. So we recommend reaching out to them if you have any questions or your patient or donor need consultations. All right. So once again, you can see that there are many people who could be involved in medical updates and third party. You've got children, providers, pregnant people, recipients. I mean, the list can go on and on, honestly. So here we are again. So when we are investigating I can't emphasize enough how much communication is important. You can see here that there are multiple different people here. Information is being transmitted from one person to another. And it is important to keep a record, like a record that you can put in SharePoint where people can add information, download files into it, and have one person be kind of in charge of it so they can grab everything together, send it off to a genetic counselor to make that report. The clinic where the reporting recipient case is identified is responsible for trying to get all of the information from that recipient to provide to third party or to the doctors. So example, if RMG has a case where one of their patients had a child who had a condition, they're responsible for pulling all that information. The donor program or MAB coordinators, depending on where that donor came from, would be responsible for notifying the other centers' patients. So if, there's an IFI patient and a CRN patient, we would take that responsibility on notifying those patients and possibly doing additional testing on the donor as well. So when a gamete donor is involved in an adverse outcome, the information could affect more than just the reporting recipient. We all know that donors tend to go to multiple different families, sperm donors especially. So we are looking at the reporting recipient, their future children, if they have embryos left over. We're looking at the donor, him or herself, that may affect her pregnancies, her children in the future, her health. The donor's family, if there's an autodominant type condition that has been found, any other recipients who have used the same donor, combination for their pregnancies and children. So it does span out. It's not just one person who is affected. There could be 20 different people affected just by one case. When you do conclude the case, and you're ready to send out notifications to these recipients or family members, we need to make sure that we include a great description of what the condition is, what its inheritance pattern is. Is it recessive? Is it dominant? Is it X-linked? What that potential reoccurrence risk may be for future children. Is it up to 3%? Is it 50%? Or is it going to happen? If there is any information available on testing embryos, if PGTA is an option, if PGTM is an option, we need to have that information also in this report. And finally, we need to make sure that we give them options for medical treatment if we can. The notifications can be very time sensitive depending on when the recipient is in her cycle, and we'll talk about that on the next slide. So you figured out what the case is, and now you need to notify your recipients. Recipients can go, we send eggs out, but they're not always going to inseminate them immediately. So as a practice, I personally reach out to these centers when we are aware of an adverse event that we are investigating. I give them the heads up saying, hey, we got this notification very recently. We're working on getting more information, trying to figure out what the cause is. If there is a higher reoccurrence risk, please tell me where your patient, ABC, is in her stage. Is she pregnant? Does she have embryos and she's planning for an immediate transfer? Is she planning on inseminating immediately? And if those three cases are, if that's where the case is for this particular patient, they may need to know a preliminary notification so they can adjust their plans if needed, or have extra ultrasounds, a fetal ultrasound to look for something specific, like if it's a heart condition. They could hold off on their transfer, or they could hold off on insemination. Once the case is complete, of course, these patients do need to be notified, but we also need to notify the patients who have frozen embryos but no plans for a transfer, or have gametes frozen but have not inseminated and don't have any immediate plans for insemination. And we also need to reach out to any patients who have children thanks to this donor. The donor gamete bank is responsible for these notifications. So we will email the center and the patient together, provide a letter and a summary in that email. So they will have the information they need. And we also provide or offer free genetic counseling for those patients if they are interested. If there is not an increased risk determined after our investigation, a notification is not required, but the information can be stored and available for recipient view. All right, so considerations when determining which medical updates warrants notifications when a donor is involved. Can we do anything? Is there some testing that we can order? Is there PGT available? Would it affect this person's decision to use any embryos or gametes? Does the medical update have an increased risk of happening again? If it's 3% or less, or is it 50%? We need to have those numbers available to determine this. What's the quality of the report? Do we just have a verbal communication with the patient without medical records, or do we have the whole file and every bit of documentation we need to determine what the cause is? And with this information that has become available, would that make the donor ineligible? Would she have passed the initial screening had we known this before? Is it a major or a minor malformation? Again, as Lori pointed out, there's another link to the CDC information. Is it dominant? Is it X-linked? All this information is something that is considered when we're determining if a donor is eligible or ineligible for return donations. And again, here we are again with more information about if the donor is eligible or not. So if the investigation identifies an increased risk for a major medical or developmental condition, then the donor is no longer considered eligible. The eggs that we have frozen still in inventory will be removed from the site. If we do have patients who have gametes that are still frozen and unused, we will recall those back and then let the recipient pick another donor. If the risk is we're not real sure, or it's a little bit low, she will still be unavailable for new matches. But if she has a request, or they have a request for a sibling match, meaning they want a full-blooded sibling match, we may consider that depending on what the actual outcome is. That recipient should receive additional genetic counseling from a certified genetic counselor to specifically go over that risk. And there should be a waiver sign or a counseling note available indicating that the patient is aware, they understand the risk, and they're willing to move forward. If the investigation says that there's not an increased risk, or if the adverse event is determined to be minor, the donor is still available. She can come back in for additional retrievals. We can continue selling her eggs. But on a case-by-case determination, we may need to update the genetic risk assessment and donor profile to show what the specific event was. So additional parents who are new parents can look at that information and determine for their family if they're okay with it. So, as we said, we have done many cases together, and here are a couple of reasons, why medical records are so important for us. We had a recipient who used one of our donors, and the child was born with a congenital heart defect, and she had surgery at 4 months old and was fine. We sent out a letter to the recipients, letting them know the reoccurrence risk, PGT M is not available, and an echocardiogram for new pregnancies would be recommended. Later, after the letter was sent, the patient provided us with additional medical records, which indicated multiple anomalies in a child suggested of a genetic syndrome, sorry. Whole genome sequencing or whole exome sequencing has been ordered. We are still pending test results for that. And depending on the findings, that reoccurrence risk might go from 1% to 3% up to 50%. If that is the case, we're going to have to send out another letter. PGTM may be something that could be looked into at this time, and it may have a greater impact on the other recipients' decision on using these embryos. Another case that we worked on, which is probably my favorite, we had a patient reach out in 2019 that their child was diagnosed with autism. We sent out the letter to all the patients. She had, I think, 23, 24 patients, multiple children out there, letting them know, hey, there's a half sibling who had autism. There's a 1% to 3% reoccurrence risk. It's multifactorial. Thank you. Then later, a couple of years later, we got an additional autism diagnosis in a set of twins. That was pretty severe. So we updated or reopened this case and did some more homework on this donor, and I found a list of other outcomes that have been reported or we found out after this other notification. There was a pediatric cancer, there was a cleft palate, there was osteogenesis imperfecta, epilepsy, juvenile arthritis, and a third case of autism. One of these patients is having genome testing or exome testing on one of the twins, one of the severe cases with the twins. And we're waiting on those results too to see if there is something that's linking all of this together. Depending on what those results are, another notification may be needed for these cases. And this one is one of Lori's that she would like to speak to you about. You're on mute. Yeah.
Myself. There we go. Now you can hear me. Hopefully, yes?
Yes.
Okay, perfect. Thank you for going over all the complexities of investigation and notification and the huge significance of medical records that can weigh into the accuracy of what we're able to inform on. In this situation, this was not a third-party case, but illustrates how things certainly can change during the course of care. So this is a couple that pursued IVF with PGTA, just based on maternal age. They had their first euploid embryo transfer, which was successful, and a baby girl was born. Not long after the baby was born, unfortunately, the family started observing that she was having seizures, and she wasn't meeting her developmental milestones as the family and the pediatrician expected. And because of these things, she was referred to genetics. And in the care of pediatric genetics and other specialists, they started an evaluation to see what might be the cause. And they discovered that The baby girl had a single gene disorder that was the cause of the condition. Interestingly enough, this is a condition that was on the carrier screening panel that the parents had done at the beginning of their care with the fertility clinic. And the mother had an identified pathogenic variant. So we already knew that she was a carrier for this particular condition that her daughter was diagnosed with. But the father had negative carrier screening. And when the daughter's testing was done, it was clear that she had inherited mom's known pathogenic variant, but she also had this variant of uncertain significance. So variants of uncertain significance are not routinely reported on carrier screening. It's just kind of not the scope of carrier screening. It's not the intention of carrier screening. So when we went back to the carrier screening lab and said, this is the situation, when you go back and reevaluate the father's test, do you see this variant of uncertain significance? And in fact, they did. But per standard carrier screening protocols, they did not report it. But in the context of having an affected child, that what we would have thought to be a variant of uncertain significance surely seems contributory to the daughter's diagnosis. So it's really going to be, especially for this family, considered more of a pathogenic variant. Now that we know the two gene variants that cause the daughter's condition, we can offer PGTM with that information so that any of the remaining embryos can be tested. Any of the euploid embryos can be tested to see if they have both the father and the mother's variants and would be predicted to be affected, and then obviously would not be transferred. So it's a pretty dramatic case where the information for a newborn after treatment significantly impacted how we would care for this family with subsequent cycles, with subsequent treatment. So one thing that I really want to point out, and Amy was speaking to this before, but managing adverse outcomes is really emotionally challenging for everybody involved, including care providers. You know, obviously for patients, we want to make sure that they've got mental health support. If they don't have that, hopefully there's a mental health provider that your clinic works with that you can connect them to. Support from the MD and the care team, even though it's really difficult to sometimes be on the receiving end of the anger and the confusion and the just despair that they're feeling, we really do need to support them. If there's a genetic counselor at the clinic, or if you're involving GeneScreen to be able to help, and also make sure that they've got the support of their family and friends. Oftentimes, if this is a pregnancy that has a complication or is being ended, or they've got a newborn that has a new genetic diagnosis, they've got a lot going on. So making sure that they've got a good network is important. And then for us as care providers, we need to remember our self-care as well. And sometimes having our coworkers help us shoulder that emotional burden is really helpful. And remember that I'm here to help review cases and certainly kind of talk about how hard it is to manage these cases. I'm here for your support. And Dr. Alice Domar, Ali Domar, our Chief Compassion Officer, is available as well. She certainly can be a sounding board and a resource. She does not do direct care, but she can certainly help guide you in direction where you can get some support for yourself in managing the emotions of dealing with these adverse outcomes. So right now, we're talking about how to handle things internally and some recommendations and some guidance for us internally, but there isn't really a professional organization like ASRM that has clear guidance on how to manage medical updates. and adverse outcomes. So there's a group of genetic counselors that are working in reproductive medicine and in gamete donor facilities and in advocacy that have started to come together and create some guidance. And we're currently working on a publication that hopefully will be published through one of the ASRM publications. So stay tuned for that kind of additional support, outside of the organization. Until that is available, though, you certainly have me as internal organizational support. So just to wrap things up, I know we're going a little bit long. This is a pretty complex topic, but just to summarize, remember that we've got a number of means of doing genetic risk assessment in our fertility setting. The personal and family medical review for patients and donors is really key. If there's anything that ever comes up in a family history where you're questioning it, feel free to reach out to me. Genetic carrier screening of patients and gamete donors, and then also pre-implantation genetic testing. These are all tools available to us in our care setting. And remember that medical updates can have a huge impact on patient care and can significantly change reproductive decision-making. And adverse outcomes really do need to be investigated to determine if there's additional testing or treatment that's warranted to help address that risk in subsequent care. And genetic counselors, myself, GeneScreen, maybe your internal genetic counselors can help with the investigation and give provider support, our care team support, and additional testing coordination, and also patient counseling. So we're here to help you with this. We recognize it's incredibly complicated and taxing for everybody. So with that, I would like to see if there are any questions or any points for discussion. Here's my contact information. If you do have questions about cases, please don't hesitate at all to reach out.
Great. Thank you, Lori. Thank you, Amy. That was very informational, and I really, the case studies were very interesting. For our team members that are on, if you have any questions, you can always kind of raise your hand or put them in the Q&A box, put them in the chat, or I can also unmute you if you have any questions. I see there are a couple of clinicians on here, a few nurses and nurse practitioners. So again, if you've had a case before that you weren't quite sure what to do, feel free to share that as well with us. Hi, Liz. You can now unmute yourself. Hi, Liz. Did you have a question?
Oh, I see you're unmuted, Liz, but I'm not able to hear you. I wonder, maybe you want to type it in the chat if your microphone's not working properly.
Yes, you can certainly type it out, Liz. I know it's hard sometimes. We never, some of the computers don't really have great microphones.
Yeah. Technological issues.
Yes.
Yes. They do arise for our cameras and mics.
They sure do. The question from Liz is, when do we need to notify MEB about a medical update?
As soon as you get it. Yeah.
And Amy, could you let who on the MEB team should they be contacting? Is it you directly?
It's me.
Amy, do you want to put your, just in case folks don't have it handy, do you want to put your contact information in the chat? Or I know that there's a specific email address. I think is it outcomes@MEB?
I'm gonna put mine in here, but I think it is outcomes at MEB, but I'm not 100% sure. So there I am, and then Teams always.
And Liz
Teams is
asks,
great.
do you want us to continue using the AE form or do you have another form?
No, I don't need any forms. I just need like either the email forwarded to me or the documentation forwarded to me with like a real short email summary.
Okay, any other questions from anyone?
And I'll just add that when you reach out to Amy, you're also reaching out to me. Amy's your point person at MEB, but I'm always right behind her. And we work pretty closely as a team to investigate and work through notifications. We meet every other week to go through cases and see if we can make some progress on any open cases to get to a place of notification. So it is a regular thing that we do.
Yes. And we talk in Teams every day too about updates and stuff too. So when I know something, Lori knows something. I did want to say too, if you guys are putting in outcomes in EDC, which is our donor management system, there is a note box at the bottom. So if there is an issue with the pregnancy or if there is some sort of genetic defect, you can type in information there, and any TABs, SABs, or cycles that have notes get emailed directly to Lori and myself. And we immediately look at them, see if there is an issue. If it's an SAB that's past 14 weeks, we want to know what happened. If there's a TAB, obviously we need to know what's happened. And if a child is born and something comes up on screening, or if there's a cleft lip or anything like that, just type that information in the summary, and then we'll reach out to you to get more information.
Yeah, Egg Donor Connect or EDC is a great resource to be able to share this information and keep MEB updated. Not only keep your clinic records updated about a donor, but it also triggers notification for my egg bank too.
Yeah, so just make sure it's in the notes section, because in that case I was talking about earlier, the autism case with the multiple other updates, someone did put a note in the about one of those conditions that I mentioned, but they did not put it in the right place. They checked a box and just added information. It was other or something like that. So make sure it's in the actual notes section, because that's what triggers a notification to us.
And then the next question is MEB still sending email notifications to IPs involved?
We are, yes. And we copy the centers on them. The center gets a notification first as a heads up, and also to get information about their patients who have used the eggs. But once the case is complete, we follow up with an email to the patient with the center copied.
Okay, and this is regarding the adverse outcome, correct?
Mm-hmm. Adverse outcomes or medical updates, both.
Great. We have another one that's not a question, but says, appreciate you for all your time and amazing information and examples.
Oh, thank you.
Very welcome. Thank you.
Right, and it looks like we are almost at time now. You will receive the recording of the session. Feel free to share it with any colleagues, anyone else that you think might have interest in this. There will also be a little survey to tell us what other topics you would like to hear about, specifically from Lori and Amy around genetics, genetic testing, any other topics. If you would like to have a session specifically for your team, if you're one of the clinics that doesn't have an on-site genetic counselor, they're always more than happy to lead any in-services for your team. Please reach out and we can, of course, get that scheduled for your team. We want to make sure you're all feeling empowered and have the knowledge that you need to serve your patients best. And we really appreciate you taking the time to be with us this afternoon.
Thank you,
Thank
everybody.
you.
Thank you all.